Good morning. This is a brave group to get up and come early for a breakfast and a talk on asparaginase. So this is a talk being given by ACCME Oncology, maximizing asparaginase utility in pediatric and young adults with leukemia and lymphoma. Practical tools for oncology nurses. And this presentation is actually supported through an independent educational grant from Jazz Pharmaceutical. So as with you all, this is a different way of presenting with the iPads. So if I have any questions, I may have to say, hey, help. So anyway, I'm Belinda Mandrell. I'm actually the Director of Nursing Research at St. Jude Children's Research Hospital, and am happy to present this information on asparaginase. Anytime I give a presentation, my primary objective with any presentation is that everyone comes away at least learning something. You want something new, some caveat that you can take back to your clinical practice. So I hope that today during this presentation that you will all have something that you learned during the presentation is like a kind of an aha moment that you think is something that you will take back to others. And first of all, we'll talk about our learning objectives today. We're going to identify the essential role of asparaginase in pediatric treatment protocols. We're going to differentiate between the available asparaginase formulas, talking about the route of administration and safety profile, and lastly, utilize recommended strategies to monitor and manage the asparaginase-related toxicities and hypersensitivity, which for you as pediatric oncology nurses is what you deal with, particularly if you are in your infusion centers and you're the person giving these particular medications. So as I said, the first objective, talking about asparaginase in pediatric and young adult ALL and lymphoma, identifying the essential role of asparaginase in the therapy. And I think this is something where we as nurses, it's really fun to kind of have a better understanding of what's the biochemistry and how the particular drug actually works. And you all as pediatric oncology nurses very much know that ALL is the most common childhood cancer, and it's predominantly, and it is in the B and T lymphocytes. Actually, of the ALL in children, it's predominantly about 80% is pre-B, and then, typically we say about 20% is T cell, and I always put in there about 1% is your mature B cell or your B cell lymphomas. We know the clinical presentation, of course, you know that well, of the cytopenia, the adenopathy, and the symptoms that our patients present with. And then the diagnosis through the immunophenotype, the flow cytometry, looking at the biomarkers of the CD10, 1920, and all the biomarkers to differentiate between that being B and T cell lymphocytes. Now, this next slide is kind of busy, but I wanted to just show you all this because I think that particularly if you work with leukemia, I would reference this particular article. It's by Dr. Anama and Charles Mulligan at St. Jude from my institution. It's in the European Journal of Hematological, and it's 2020, but it goes through all the categories of B and T cell lineage. And I think the thing that has changed so much from my having been in pediatric oncology for 30 years is our understanding of all the different categories now of different sublineages of B cell and their prognostic implications. And one other thing that I think that this chart shows is it gives you a very good description of that particular translocation or fusion or amplification, but it also gives you potential therapeutic implications where we may see more of these inhibitors being added to improve the outcome for our patients. And so here, starting with some of the known cancers that have the better prognostic, like the T1221, and then those of the poor. So it goes through all of this, and I think it's really a good manuscript if you all are leukemia nurses, and gives you that stratification. And then further on, the manuscript also goes over that of the T-cell lineage leukemias, lymphomas. As a nurse, you also know the differentiology between the lymphoma leukemia as being the amount of blasts within the bone marrow. But we know with the T-cell lymphomas, they're treated similarly as their T-cell leukemias. So when we talk about treatment for ALL, we know that this was really the medical success. I know from our institution, this is really the disease that really started the trajectory of success in pediatric oncology, because as my institution started in the early 60s, we only had cure rates for ALL of a dismal 4 to 5%. And then as we started combination therapies, our cure rates began to improve. And here on this graph, you can see the trajectory of improvement in the treatment of ALL. And we know that this is really related to a lot of innovations that have occurred with our knowledge of leukemia. But you can see here that in 1978, asparaginase was approved by the FDA. And if you look at the, it's like the 1, 2, 3, 4, 5, the fifth line, the red survival curve, that's actually when we started having the implementation of asparaginase into the treatment protocol. What's so different when you think about the approval of asparaginase in 1978 compared to approval of medications now, we really are on an FDA fast track with medications. Medications can be found to have efficacy, and we can really are getting a lot quicker turnaround in that approval process. But the work for asparaginase actually began in the later 1950s and the early 1960s, and it took until 1978 for it to actually be approved by the FDA. So you can see that there's been a significant change in the lag of time for particular drugs to be approved. So the therapeutic role of asparaginase in the treatment of ALL, I think, is really fascinating when we think about what asparaginase does. And actually, asparagine is actually an amino acid that's needed by all cells. It's needed by our normal cells, but particularly there's a difference in that our normal cells actually synthesize their own asparagine. So the leukemia cell, though, is dependent upon the asparagine in circulation, in the plasma. It needs that for survival. So the hallmark of asparaginase is essentially to deplete this plasma asparagine. And then by depleting it, it kills the lymphocyte because the lymphocyte needs it for survival. And you can see here that if you deplete with asparaginase, the asparagine, then you have the breakdown of aspartate with ammonia. So the asparaginase will actually hydrolyze the asparagine to aspartate acid and ammonia. Thus, it inhibits the cell growth and activates cell death. So we're really blocking the uptake of asparagine by the leukemia cell, promoting cell death. So when we, and it's so funny, I'm so accustomed to my PowerPoint being over here, and I want to do this and point to something, but in this diagram, instead I have to look at the floor. Instead, this diagram shows asparaginase as being basically what they term the magic bullet. So in the plasma, we have the asparagine that is needed by the leukemia cell. So the asparaginase actually blocks the asparagine, and then we have the glutamate that is left, and we then have the breakdown of asparagic acid and glutamic acid that then go into the cell. So we've got the uptake of ammonia, and because asparagine, or the asparagine amino acid, is essential for the production of proteins and the protein synthesis of the cell. So then downscale, or cascading from this, we block the protein synthesis, so all the proteins are affected at a price. And that's what we see then that happens in our patients, because they've got predominantly all lymphoblasts when they're getting treated in induction for their ALL. So now we have disrupted the protein synthesis, and we'll then have hypoalbuminemia, we'll have increased cholesterol, we'll have changes with drug metabolism, we have coagulation disturbances, we have hyperglycemia, and then we have organ toxicity. And it's because we have disrupted that protein synthesis. And then we will also have increased ammonia as a byproduct. So we know that most of the pediatric, or all the pediatric ALL treatment protocols include asparaginase within the protocol, and this is just some of the examples of when asparaginase, particularly here listed as PEG asparaginase, is included in the induction protocols. So it's an essential drug for the induction and the intensification of our patients with leukemia and lymphoma. This is just a survival curve for patients actually ages 17 to 39 years of age. And we know young adults actually have a poor prognosis, particularly in adults with acute lymphocytic leukemia. But over time, the overall survival has improved. And we can see here, this is primarily because the young adults are now being treated with the pediatric protocols. That intensification, that intensive induction, consolidation, and the use of asparaginase. And you can see here the overall survival curve for patients that are of young adult. And then by immunophenotype, we know that those with the B-cell lineage compared to the T-cell lineage have a bit better overall survival. The other interesting component with patients with ALL, we know that in children, hypodiploid is a poor prognostic feature. And fortunately, it's not a common finding, but when we do see hypodiploidy among our pediatric patients, we know it's a poor prognosis. What we know with adults with ALL, that they more often do have the hypodiploid leukemia. This is another interesting component, and that is CNS involvement in relapse risk. And so here you can see that we're looking at the cytospin. So when you do in lumbar puncture, we know at the time of diagnosis, we send that spinal fluid off for cytospin. We look at the number of white cells and the presence of blast. And you can see in this first column, we're looking at one study that looked at those that were positive compared to negative. And what's interesting now is that we know that we should also be looking at our spinal fluid with flow cytometry. And you can see here in that column where if you look at a spinal fluid with flow cytometry, you actually find more or a higher percentage of patients with positive CNS disease. And so when we look at the occurrence of relapse, according to CNS status, we see that the patients with CNS1 and that are flow cytometry negative will only have about a 1.6% chance of having a CNS relapse, while those with CNS2, CNS3, and flow cytometry will have about a 5.6% chance of CNS relapse. When we look at isolated bone marrow relapse, we find that those that are CNS1 and flow cytometry negative will have about a 3.8% bone marrow relapse, while those that are CNS2 and 3 and flow cytometry positive will have about an 8.2% isolated bone marrow relapse. So we know that the CNS involvement is very important. And the thing that I would say is that we probably have underestimated the occurrence of CNS positivity among our leukemia patients, because prior we have only looked at the cytospin, and now it's important that we also look at the flow cytometry that may be giving us a higher inference of those that are positive. And we know that asparaginase is also important in treating the CNS leukemia, and that the CNS positive by flow is higher, as we said, in those that have a subsequent relapse of the spinal fluid and the isolated bone marrow relapse. And so one of the things that we always looked at when we were doing our spinal taps back in my day as working as a nurse practitioner is we would look at a traumatic tap. So we would be very concerned if we had a traumatic tap, and if that had blast, we would consider that patient CNS positive. But now, if you did flow cytometry and the flow is negative, that patient would be considered at a low risk of CNS relapse. So it's not as significant should the patient be negative by flow. And one of the reasons, now when we're doing a tap, collecting one for cytospin, one for flow cytometry, is that you've got to be really cognizant about getting that flow specimen quickly to the lab for processing. So now when we look at the different asparaginases that are used in treatment for leukemia and lymphoma, we know there are different formulations and routes of administration and safety profiles accordingly. So our most common drug of asparaginase used is our pegylation model of asparaginase. So you actually have this polyethylene glycol molecule attached to the asparaginase. And the significance of this is that it increases the size of the molecule, the molecular weight. It improves pharmacokinetics and pharmacodynamics. It improves the water solubility. It has protection from the enzyme degrading. It reduces renal clearance, and it limits the immunogenic and antigenic reaction. And this is why a lot of our vaccines now have the pegylation also coupled on it as a vehicle, particularly if you remember the COVID vaccine also is a pegylated vaccine. And it will also increase the half-life. And so you can see with any vaccine, the importance of having the pegylation is that the vaccine can really be in the immune system longer and will not be depleted and can actually create that immunological response. But we know with the pegylated asparaginase, the beauty of this is giving it it's less often administered because of the increased half-life, and so therefore we have less frequent administration. So I guess you all got a lot of comments or thoughts about when the COVID vaccine came on board, a couple of years ago. Could your patients that had allergies to pegylated asparaginase also receive the COVID vaccine? Do you all remember that question coming up? So the answer is they can, because probably about 25% of us actually have a sensitivity to a pegylated product because we've all been exposed to pegylated products. They are the vehicle in many of the medications we take, even things like laxatives or things that we want to stay within our system longer have this pegylation. So there's really no concern moving forward with the COVID vaccine should your patient have a pegylated allergy. So we know that there are now 2 pegylated asparaginase products on the market. The one that we probably use all the most is this first one, the pegylated asparaginase. It's given IM or IV, and particularly most of us give this IV. Several years ago, Emily Brown and I did a retrospective review of asparaginase infusions with the pegylated formula because it was our policy that anyone getting an asparaginase product had to stay within the hospital for at least 30 to 40 minutes after the infusion or the IM injection so that we could monitor for hypersensitivity. And what we found, and what you all know, when you give IV pegylated formula, your patient is going to react within a couple of minutes. So by doing a large retrospective review, we found that most reactions on the IV pegylated formula would occur within the first 5 to 10 minutes, and they were more likely with the second and third dose. So we were able then to change the policy that those that had a complete infusion of the IV pegylated asparaginase could be discharged from the infusion center after the completion of the infusion because we were not afraid of a delayed reaction with the IV formula. And then there is recently a new formula of asparaginase, and the advantage of this is that it has a half-life that is longer, and that being about 16.2 days. But this is just being introduced into therapy, and the application of this is not as well described. So one of the difference in these 2 new formulas of the pegylated asparaginase is that the newer PEG asparaginase, cal asparaginase, is that it has an additional linker in the molecule. You can see that you're through the cascade, the biochemistry cascade, that there's a little bit difference because it has added an SC linker in this newer formula as it moves through the biochemistry change in the outcome in depleting the asparagine. So besides the 2 products of PEG asparaginase, we know that patients may have to be taken off of PEG asparaginase and then go onto an Erwinia product. And now we know that our previous Erwinia product was very difficult to obtain. It was made in Europe, and we continuously had a shortage. So the thing that is pushing our use of asparaginase forward now is the introduction of a new asparaginase Erwinia product, which is a recombinant that now is available for our patients. And the other thing that is advantageous is that it also has a longer half-life and can be given for our patients that can no longer tolerate PEG. It's been approved by the FDA and is easily available now in the United States, so we no longer have that issue of the short supply of Erwinia asparaginase. So we'll talk a little bit now as we look at asparaginase and talk about the toxicities and the hypersensitivity, because this is what you as oncology nurses see in your practice, and particularly if you work in the infusion unit with the hypersensitivity. And as I talked about, asparaginase, it is a magic bullet because it is eliminating an essential amino acid that is needed for the survival of the lymphoblast. But at the same time, we know there's a cascade of events that happen related to the lack of synthesis of particular proteins and the buildup of the ammonia. And so because of the protein biosynthesis disruption, we've talked about all of the things that we see that then happen with our patients downstream. So we know there's the efficacy that we've talked about, and that's easy to understand, is that the asparaginase breaks down the asparagine that is needed for the survival of the lymphoblasts. But then we balance on this whole level of efficacy versus toxicity that we have to watch for, because we know that our patients will and are likely to have some of these related events during their therapy on asparaginase. And so here we know that one of the first things is the hypersensitivity reactions, the issues with hepatic, pancreatic, the hyperglycemic, the fatigue, the encephalopathy. We have increases in our triglycerides. We know that it can result in thrombosis and also in cerebral hemorrhage. So when we're looking at our toxicities, the most common toxicity or related toxicity to asparaginase is the hypersensitivity. And there are two types of hypersensitivity. One is the actual allergic reaction that we see with our patient, whether they have the bronchospasms, the shortness of breath, the tachycardia, all of those that we know associated that could lead into an anaphylactic reaction. Or we have silent inactivation, and that's really even more significant for our patient, because by having silent inactivation, we know that the drug is not working. The asparaginase is not depleting the aspirine. So that is really the most significant implication that we need to remember. Of course, we got to treat their hypersensitivity reaction, but if the drug is not working, that is really significant hypersensitivity. We know that next is the toxicity to the liver. We'll see their bilirubin go up as well as their liver enzymes. And we know that the incidence of having your liver enzymes go up is pretty significant. Incidence of grade 3 to 4, greater than 50%. We'll have some hyperbilirubinemia. And then we know that thrombosis can also be an issue with deep vein thrombosis or the sinus thrombosis, which can occur. Pancreatitis, looking at your lipase, amylase, increase in your triglycerides or your cholesterols, all your lipidemia occurring. And then we know that we can have CNS toxicities, the encephalopathy, and those are less common. Fortunately, the pancreatitis is less common as well. So our most common concerns are with the hypersensitivity, the inactivation, and the liver, followed by the clotting. So it's really interesting to look at the prevalence or the predictors of asparaginase toxicity, and what are some of the factors that you as nurses may think, oh, this patient's these are the predictors of toxicity. And here we have it broken down by age, and we can see that anaphylactic reaction to asparaginase is more likely to happen in our younger patients. Patients 9 and less are more likely to have some of the hypersensitivities. Our older teenagers are more likely to have the pancreatitis. Our older teenagers are more likely to have the changes on their lipid profile. And our older patients are more likely to have the thrombosis. I remember in clinical practice, it was always the teenagers that you became concerned about. Particularly for some reason, I remember it was the male teenage boys that would come in with these headaches after asparaginase, and you would find that they had a sinus thrombosis. So these are always some things to think about. So age is really a predictor of toxicity with asparaginase. And another thing we know through the trajectory, of our ALL patients, their BMI is also a predictor of a lot of outcomes, particularly even late outcomes with our patients. But here you can see that patients that have the higher BMI, they're more likely to have hepatic toxicity, and this may be related to the fact that they're more likely to have a fatty liver, and they're more likely to have their hepatic enzymes go up and have higher bilirubin levels as well. And then because of the hepatic toxicity, they're also more likely to have the hyperglycemia, which we see. So BMI also is a predictor of toxicity associated with administration of asparaginase. So looking at age and BMI, you know who is more likely. So be on alert for those persons with higher BMI for more liver toxicities, and our older patients to have more of the pancreatitis and clots and things of that nature in regard to toxicity. So one of the biggest reasons that we would want to change PEG asparaginase, particularly a major reason besides hypersensitivity, is the silent inactivation. And this is when we can develop antibodies that lead to this inactivation of the asparaginase. And this is monitored through the measurement of serum asparaginase activity by therapeutic drug monitoring. And how many of you all in your institution do therapeutic drug monitoring when you administer asparaginase? This is one thing I do not like about, so it's kind of half and half, right? So therapeutic drug monitoring during asparaginase is really, really important and can let you know that, can really alert you when you have this silent inactivation. So when you're looking at the therapeutic drug monitoring, you can't measure the asparagine levels because the asparaginase in the blood, if I were to get a sample doing a therapeutic drug monitoring, and I'm going to see, are we getting rid of the asparagine? The asparaginase is still in this tube, and it could still break down in ex vivo. So even while it's waiting to be processed, it may give us a false reading because the asparaginase is continuing to break down the asparagine. So what we actually look at is the serum asparaginase level. So we're not going to look at how well are we breaking down the asparagine, but we're looking at the serum asparaginase level, and we want this to be at least equal or greater to 0.1 international units per mil, and that correlates with clinical efficacy of our asparaginase therapy. So some of the reasons that we want to discontinue our asparaginase in children that are on therapy between the ages of 1 and 17 would be if we were to see hypersensitivity or if we saw silent inactivation. And you can see here in a cohort where the main cohort, we had hypersensitivity, and in that cohort, we had no asparaginase enzyme activity. So that particularly is where we would want to discontinue the asparaginase. And when they looked at levels, they actually saw that they had silent inactivation in 46 of those particular patients. So what is the implication if we have truncation of our asparaginase therapy? So truncation means we just stop. What happens to our patient if we stop their asparaginase therapy? And in this graph, you can see it looks at patients that had non-truncated therapy, and that is the black graph, and that's their cumulative incident of relapse. And you can see that those patients that had all of their asparaginase, they had the lower incidence of cumulative relapse, and that would have been at 6.7% risk for relapse. Those that had truncated or they stopped their asparaginase with medium intensity, and medium intensity means they had 10 or more weeks of their asparaginase, their risk cumulative incidence of relapse was at 9.4%. And then those that had low intensity, meaning they had less than 10 weeks of asparaginase therapy, so they had, they really stopped early. You can see that their cumulative incidence of relapse is 11.9%. So we know that stopping asparaginase therapy can have a significant impact on the overall risk for relapse for our patients with ALL or with lymphoma. So what are some of the predictors of the going back to the, and this probably should have been with my other predictor slides, but with asparaginase toxicities, as we also know, it's the pharmacogenomics, particularly with some of the HLA gene and variants within those can actually place the patient at greater risk for hypersensitivity. We know that there are a couple of genetic variants that can place the patients at risk for hepatotoxicity, and also some genetic variants that can place our patients at risk for pancreatitis. And our risk factors for hypersensitivity to relapse for hypersensitivity to asparaginase, we know is the formulation. We know it's greater with pegylated asparaginase. Is it the route? Is it the schedule? We know it's more often to occur with the second and future doses. Those with the HLA DRB1 polymorphism are more likely to have risk factors to hypersensitivity. The younger age, allergic to PEG due to exposures from other PEG-related containing products, and asparaginase activity level is associated with the liver hepatotoxicity. So let's look at how we would treat a patient that has hypersensitivity. So we've got a 12-year-old male with pre-B ALL. They've got amplification of chromosome 21. And I remember those that have been in oncology for a long time, I can remember now, we would see in the karyotype of the leukemia cell, they would say, trisomy 21 in the leukemia cell. And I thought, well, there's something there that's really amplified this because we know there are leukemic progenitor genes on the chromosome 21, because we know that our patients with Down syndrome have an increased risk of leukemia. But we can have this amplification in the leukemia cell of patients that don't have trisomy 21 in their germline. We can have it in their somatic leukemia cell, and this amplification of chromosome 21. And so we've got a copy number variation in that gene. So that places them at a bit more of the intermediate risk leukemia. On examination, we know he's got a white count of less than 50,000. He's CNS 2, and it's positive CSF by flow cytometry. And because this is a little bit higher risk with the CNS and the amplification, we know we need to intensify therapy. But this patient develops a hypersensitivity after the third PEG asparaginase dose, and he has grade 3 symptoms that include rash, stomach pain, bronchospasms, and reduced blood pressure. So, what are our options in treating this patient that has the hypersensitivity reaction? Are we going to permanently discontinue his asparaginase therapy? Are we going to switch to the E. coli asparaginase, anticipating hypersensitivity towards the PEG modulation? Are we going to continue PEG with pre-medication, such as we know the histamine blockers and steroids? Are we going to prescribe pre-meds at the next PEG asparaginase dose and perform therapeutic drug monitoring? Are we going to switch to IM asparaginase? Or are we going to switch to a non-cross-reactive asparaginase formulation such as Erwinia? So just think about this, and we're going to go through these different scenarios. So permanently discontinue the asparaginase therapy, and we've already talked about that. We know that truncating asparaginase therapy actually increases our relapse rates in our patients with ALL. So we know, and you can see at the bottom, that the less intensive asparaginase therapy is associated with 11.1% relative risk of relapse compared to 6.7% in our patients that receive all of their asparaginase. So we know that truncating or stopping after hypersensitivity reaction is not an option. Second, PEG asparaginase discontinuation in young adults with ALL. There was a study that found that discontinuation was defined as less than 4 of the 5 to 6 planned doses. And in this study, there were 176 patients and 57 with early therapy discontinuation. Survival was lower, but not significantly significant in this study, but this is likely because of the sample size being very small. Patients with standard risk early discontinuation, though, it significantly impacted their overall survival, but no impact in patients with higher risk. And here again, I think that you can see that with the standard risk patients, there was a significant decrease in overall survival in young adults with ALL, but you've got to remember this was a very low sample size, and likely if you had larger sample size, we know that discontinuation of asparaginase in therapy would be related to a higher risk of relapse. So the second option, switch to native E. coli asparaginase. And so here we can look at the sensitivity reactions to the PEGs. Here we've got the anti-E. coli asparaginase antibodies. You've got your IgG and your IgM. You know, I always tell my students when, you know, the great way to discern between what is IgG and IgM. So remember that the IgG is showing us a past exposure, and the IgM is showing us an immediate. And IgM is showing us an immediate exposure. So when you look at this, you can see that for the native E. coli in induction intensification, they have antibodies of the IgG and lower antibodies of the IgM. With the PEG antibodies, you have much more higher antibody production in the induction and intensification. And that means that that's more of, that's gonna really put your patient at higher risk for subsequent doses causing more significant hypersensitivity. So hypersensitivity reactions are also closely associated with inactivation due to neutralizing asparaginase antibodies. So we know that if our patient has this hypersensitive reaction, we've got to measure their therapeutic asparaginase levels, their serum asparaginase, because they may not be getting the benefit because their antibodies may actually be deleting the asparaginase that's available to get rid of the asparagine. So we know that about 90% of our patients with clinical hypersensitivity actually have no asparaginase activity. And we know that by giving the antihistamines and the steroids, that does not increase their likelihood of reactivating the asparaginase. So what we really need to do is shift to an alternative non-cross-reactive asparaginase formula unless we have therapeutic drug monitoring that really shows that our asparaginase is active. So if you have a hypersensitivity, you can re-challenge this patient if they've got active asparaginase activity. And that would be when we re-challenge them with their the antihistamines and the steroids. That is the only time it's ever recommended to move forward with the PEG asparaginase in your patients with a hypersensitive reaction, is if you know that they have the positive serum asparaginase levels. So, what's another option? Prescribe pre-medication and drug monitoring, which I've already talked about. So, what we know is that pre-medication given 20 to 30 minutes before the asparaginase reduces the hypersensitivity. Giving the antihistamines or the glucocorticosteroids are essential. Requires therapeutic drug monitoring. And remember that if their asparaginase is less than 0.1 international units per mil, that's inactivation, and they need to be changed to Erwinia asparaginase. So you can see here where if you pre-med, improves the tolerance of asparaginase. So you can see the first column is patients that had a reaction to their PEG, and then they were switched to Erwinia. And then you can see the second column where we actually did pre-medication, and you can see here that pre-medicating does improve the tolerance of PEG asparaginase. How many of your institutions actually re-challenge with PEG if you know that they're not silent inactivators? Okay, we do it at our institution as well, so we will re-challenge if they have adequate serum asparaginase levels, re-challenge them with steroids and antihistamines, and move forward, but you can only do this if you're using therapeutic drug monitoring. So, switching to IM versus less hypersensitive, is it less hypersensitive than IV PEG? And what they looked at was that there were 7 study groups that received first-line treatment with PEG, either IV, IM, and hypersensitivity reactions, 2% during induction and 8% during post-induction. So medium incidence of hypersensitivity reactions. There was really no difference between the IV or the IM administration. So giving the PEG IM versus IV is not going to decrease your risk of hypersensitivity. So option, switch to non-cross-reactive asparaginase formula, the Erwinia. So here is a report from COG, where they looked at high-risk patients where asparaginase continuation PEG asparaginase was discontinued, and Erwinia replacement on the outcome of childhood ALL. And you can see here that the patients that were missing asparaginase doses, that their disease-free survival probability was much lower compared to those that received all their PEG or were substitute with Erwinia. And you can see that those that needed their Erwinia substitution, there was no difference in overall disease survival when compared to those that received the PEG asparaginase. So we know that there is efficacy in switching over to the Erwinia when our patients can no longer tolerate the pegylated formula. So if we don't switch and our patients have the hypersensitivity, we've got to, as I've talked about before, you can only do this if you have therapeutic drug monitoring. And we know, and we have talked about this, that it's mandatory in the case of pre-medication, because we need to pre-medicate, but we need to do the therapeutic drug monitoring to assure that our patient is maintaining the levels of asparaginase that would signify efficacy of the drug. So one question people sometimes will ask is, what's the reaction to Erwinia? And the reaction to Erwinia is probably less than 1% of all leukemia patients will actually have a drug reaction. And you should also, it's also recommended that there be therapeutic drug monitoring prior to the subsequent doses of the Erwinia. But if you switch your patient from a pegylated formula, the risk of reaction is much less, is really kind of nil. So we go back to our high-risk patient, and we know that this patient has an amplification on chromosome 21, treated high risk. They have hypersensitivity after their third dose. And our question here is, how would we treat this patient? And you can now use your iPad to discern how would you treat this patient moving forward who has a hypersensitivity reaction to their PEG asparaginase. Okay, so we all got that component. We don't stop the asparaginase. Some said switch to native E. coli, anticipating hypersensitivity towards PEG. And let's see, continue with PEG with pre-medication, pre-medicate at next PEG dose, and perform therapeutic monitoring. Switch to intramuscular PEG, anticipating less hypersensitivity, and then we switch to non-cross-reactive formulation. So I can say that, yay, everyone got the first one. We're not going to stop it. We know that we're not going to switch to native E. coli. This product is no longer available. Continue with the PEG with pre-medication, and the other one states pre-medicate at the next PEG and perform therapeutic drug monitoring. So let me tell you about those, is that if we're going to pre-medicate our patient, we can only do that if we have therapeutic drug monitoring, because you will not be able to pick up when the patient potentially develops silent inactivation. This is what my institution would do, is if we know that they still have asparaginase activity, we would pre-medicate them with the subsequent dose, but that's only in the face of therapeutic drug monitoring. Switch to intramuscular. We showed in the slide that there was no difference in the hypersensitivity in the pegylated asparaginase. So that question's a little ambiguous, because some people may think, oh, we'll switch to IM or Erwinia. But remember, if you're going to go with PEG IV or PEG IM, there's no difference in the hypersensitivity. So 57% said switch to non-cross-reactive asparaginase formula, the new Erwinia that now is available, and that would be the most feasible switch if you are not able to do therapeutic monitoring, if you know that your patient has not had silent inactivation. But for any patient with silent inactivation, or in a patient that has significant hypersensitivity, and you are unsure of their therapeutic monitoring serum asparaginase level, you would switch to the Erwinia asparaginase. And we know that the pegylated advantage is that we can give it over fewer doses, and it has a longer half-life. But in the view of silent inactivation, that is the most significant reason, because silent inactivation of our patient and not switching is equivalent to truncating asparaginase therapy. And we know that truncating asparaginase therapy in our patients with ALL is significantly associated with their risk of relapse. So we've talked about this. We've talked about adverse event prevention and mitigation of hypersensitivity. And so we know that if our patient has the hypersensitivity, that they should be treated and proceed with PEG, and I've talked about that only in the view of therapeutic monitoring. So in summary, a hypersensitivity-like reaction requires therapeutic drug monitoring. You may look at slower infusion rate, pre-medication, and re-exposure to PEG if your patient continues to have therapeutic drug levels. Hypersensitivity towards PEG, especially if the reaction is the first to second dose. We know that few centers can measure the specific PEG or the SS linker antibodies, but true PEG asparaginase hypersensitivity, we would want to switch our patient and always look and switch if they have asparaginase inactivation. And as I talked about, that's what we have in summary. Pre-medicate if you have therapeutic drug monitoring, and if you know if your patient continues to have hypersensitivity, consider switching to Erwinia. And we know in silent inactivation of the drug, you always switch to Erwinia. So what we want to do in our therapy is put information into action, and our goals would be to decrease the number of pediatric and young adult patients with ALL who can discontinue asparaginase. We have to move forward, even through these toxicities of hepatotoxicity, pancreatitis. If you look at the risk of these sequelae related to the drug versus the risk of relapse, we know that we need to move forward with the drug. So we need to assure that our patients get the prescribed doses of asparaginase, and we need to increase the number of patients who are appropriately managed following a hypersensitivity reaction to PEG based on the grade of infusion-related reaction. So, time for any questions, and if it's a very technical question, I'm happy to refer you also to a pharmacist that I have in the audience. So, I hope you have a better understanding of how to manage and when to switch your patients to the Erwinia product that we now have available, because there's clear indications, and particularly knowing if you don't have the availability of the therapeutic drug monitoring, it may be better to do it sooner than later to assure that your patient is not experiencing silent inactivation of the pegylated asparaginase. Any questions? Yeah. But you're doing it 1 hour before the infusion?
After.
Oh, after.
About 90 minutes after, because it's the same day. We don't have to bring the patient back, to the clinic, a week later, and not do anything. Would you recommend, and a lot of the protocols, have that built in, that you can do it from 1 hour to 1 day, 7-day, 14-day. In your experience, do you just do the 7-day as a better indicator, or is 1 day still sufficient?
Well, what we sometimes do is do it before the next dose, and or do it that 7 to 14 days, because if you do it immediately, do you know when they're typically looking at that? I can find out, particularly from our pharmacokinetics, but most of the time you want to see, you're not getting your full benefit of your asparaginase. Remember, this has got a long half-life. So if you do it so soon after the dose, you're not getting that full exposure of your drug to know what your asparaginase serum activity is going forward. At either of those time points. Yeah. And they're doing that for convenience, but so COG has to have the data to assure that they are getting this, that there's a reason that they say, okay, we can do that within this time period. But I think that you're getting the better drug, you're really looking at the better drug serum if you give the drug time to actually break down and see what the true drug reactivity is. So I like the 7 to 14 day better, but if you see that you've got asparaginase activity soon after giving the drug, we know with that half-life that you're going to have that same activity. So I'm sure and know that there have been pharmacokinetic studies done showing that if we do the asparaginase level within 1 hour after administration of the drug, that it correlates still with that at 7 and 14 days. What are the options if a patient has a reaction to Erwinia? Well, we know it's not likely, but then if they did and we know that they can't tolerate pegylated asparaginase, then we have no other option of asparaginase, and they would have to truncate it depending upon that type of reaction. So, but remember, that's less than 1%. Has anybody ever seen a reaction to Erwinia? What kind of reaction? Did you proceed and pre-medicate?
Yes.
And then did they do better?
They did better with a lot of drugs, and it was very, very, very long time.
Okay, so that was with the different Erwinia product. So, okay, yeah. Because that was, now we're using the recombinant, and that would have been the native E. coli. Okay. So do you do the therapeutic drug monitoring with every dose or just after the first hypersensitivity reaction? So what do you all do in your therapeutic? We look at the therapeutic monitoring. We keep up with that because of the essential wanting to know that we're not going to overlook a silent inactivation. Does Erwinia still work if there's a silent inactivation to PEG? Yes, it does, and that's why you switch to the Erwinia. And it does work after the silent inactivation of PEG. And you're going to continue to do your asparaginase levels to assure that you continue to have that, that asparaginase serum at the level of above 0.1 international units. Can you tell the difference between hypersensitivity to PEG versus hypersensitivity to asparaginase? And no, you cannot, because it is within, that's the vehicle that actually is delivering the asparaginase. But we do know that a lot of patients, even when they are diagnosed with leukemia, actually already have PEG antibodies from other medications, but you cannot differentiate between the two because it's the vehicle within the asparaginase that delivers the asparaginase. Does switching to Erwinia after relapse risk affect risk? And no, it does not, because we want to assure we're still going to measure our serum asparaginase levels, and we still maintain those levels. So it does not impact relapse if we have to switch to Erwinia. We're fortunate that we have an alternative that we can switch to another drug when we have reactions to the pegylated formula. But we know that by switching to the Erwinia, and you saw that graph that if the patient got all their PEG doses and if the patient had to switch to Erwinia, their outcomes were the same in regard to the asparaginase. So no, you do not increase the risk if you switch to Erwinia. You increase risk when you stop the asparaginase. So you're going to have to work through the thrombosis, work through the hepatotoxicity, work through the pancreatitis, because we know that truncated therapy, is the significant risk of relapse. One patient said that years ago we did not pre-medicate, though it would thought it would decrease effectiveness. Why is it okay now? And that is because we know it does not decrease effectiveness, because when we pre-medicate, we do therapeutic drug monitoring that assures that we're getting adequate asparaginase activity. So pre-medication does not decrease the asparaginase activity because we're doing that therapeutic monitoring. Okay, so this person says, I feel recently there's been a big push in rechallenging in our institution rather than switching to Erwinia. What's the benefit? The benefit of challenging versus switching at the first reaction. So remember, we give the pegylated asparaginase because it has a longer half-life. We have differences in dosing. We have to give many more doses of Erwinia versus pegylated asparaginase. So there's the convenience related to the pegylated formula. And we can re-challenge because the literature and what we've known and what we have found in study is that some of this is the hypersensitivity to the PEG. And if we pre-medicate them and they still have asparaginase levels, it's therapeutically advantageous for the families in getting that PEG dose at those intervals versus the dosing of the Erwinia. But if you don't have the therapeutic drug monitoring to assure that you don't have silent inactivation, you should switch to the Erwinia. So in rechallenging a patient on PEG, this person wants to know, what infusion rate do you use in rechallenging them? Can somebody tell me what they do when rechallenging? In slowing the infusion rate? Do you slow the infusion rate when you re-challenge? Does anybody re-challenge with a slower infusion rate? You don't change your infusion rate? You what? Over 2 hours. So you change it to 2 hours versus 1. Okay, so it looks like persons, when they re-challenge with steroids and antihistamines, they'll switch from 1 hour to 2 hours. Do you find that helps? Okay, so switching from 1 hour to 2. Any other questions? I like this iPad question because y'all don't feel like you're, I think we all should get a prize and take an iPad with us. Okay, any other questions? Well, thank you for our sponsors for this lunch. We're not at lunch yet. Okay, it's been a long morning. Thank you for our sponsors for this breakfast, and I hope you all enjoy the conference. And any questions that you all have during the meeting, go find someone and ask them. And make a point to meet 3 new people at the meeting. I always like to see old friends, but we all need to make new. So anyway, nice to see you all. Have a good day and enjoy the conference.